So we went from one extreme melanoma in situ stage 0 disease to distant meds, and now we talked about this is mainly for palliative. But what about in the adjuvant settings and then for controlling nodal disease?
Yeah, that's a great question. There have been a few studies, well-done studies, that have looked at using radiation therapy after patients have undergone lymph node dissection for their stage 3 melanoma. Generally, what these studies have shown is that the application of radiation therapy in that situation for selected patients that have high risk nodal disease can help prevent recurrence in the lymph node area following surgery. However, radiation doesn't seem to prevent the development of distant metastasis when used in this manner. So when I talk with patients about this, I always want to make sure they're aware of how radiation therapy for stage 3 melanoma can potentially be helpful, but certainly what its limitations are. And as I'm sure you've discussed in this program, the use of drug therapies for patients with stage 3 melanoma has become more and more common. And so an active question, something we don't really know the answer to is radiation therapy actually still warranted for some of these patients with high risk nodal disease?
That was
And
actually going to be my next questions. Actually, I was going to actually ask you, how does this going to be used in the setting of this immunotherapy, and especially you see some of the immunotherapy moving to the adjuvant setting in stage 2B, stage 2C disease. But sorry for the interruption. Go on.
yeah, no, it's a good question. And, the most obvious situation where we think radiation may be helpful is when we've seen that the adjuvant drug therapy hasn't prevented recurrence. The patients that, have been on adjuvant drug therapy, and then there is another, nodal recurrence with stage 3 disease. In that situation, we tend to, be using radiation therapy more often these days. But for the patients that are newly diagnosed with stage 3 melanoma, who are having adjuvant drug therapy, it's unclear whether radiation potentially adds some additional benefit. We really need to do better studies to try and answer that question at this point.
So what modality are you using? And also, obviously when you radiate the lymph node and you're running the risk of other type of much more more side effects, right? Other than just skin erythema, desquamation. Maybe we can talk about that. And what's the modality, how you go about this, and what's the fractionation dose and the side effects?
Sure. So, generally speaking, if we're treating a lymph node basin, we need a more deeply penetrating form of radiation, typically the external beam form of radiation. So in that scenario, we're typically using high energy photons, sometimes high energy electrons, and even sometimes high energy protons. It all depends on the scenario. I would say photons are probably the most commonly used. And the radiation therapy certainly can, contribute to side effects. Every time you add another cancer treatment on to the treatment of melanoma, that's going to increase the potential for side effects, and radiation is no different. The dermatitis, as you mentioned, is one possible side effect. It's probably the most common thing we see. And one of the things that's most concerning to patients and to doctors is the development of something called lymphedema, which there is a risk for following lymph node removal surgery. And radiation, in all likelihood, increases the likelihood of this happening as well. This is most common when lymph node removal surgery has been done in the groin area and radiation therapy follows. It's less common when the lymph node removal surgery is done in the neck area. So there tends to be less in the way of lymphedema that happens. It can still happen, but it's less often there. And this is primarily due to gravity. Gravity helps pull that lymphatic fluid from the head and the neck area back down into the body, whereas just the opposite's happening in the lower extremities, where gravity is pulling those fluids down, making it harder for them to go back up into the body, leading and contributing to this lymphedema problem. So, we factor in the anatomic site when we talk about, radiation therapy following lymph node dissection. We really look carefully at what the factors are for node basin recurrence. There's a few specific ones which, probably have the highest risk. And then, of course, we look at the patient's other treatment history. Have they had other drug therapies in an effort to try and prevent recurrence of their melanoma? And if they have, were those effective? If they weren't, then, we take a longer look at radiation therapy in that situation. But, like all cancer treatments, I think patients need to hear about these options, understand the pros and the cons, and then make a decision, as far as what they think is best that aligns with their goals and priorities for their treatment, for their health.
And then before I make the next point, when you talk about the radiating to the nodal basin in the neck area, and is there any risk in damaging the oral cavity and any dryness of the mouth, or is it just so focused in this region that this kind of side effect is minimal?
No, one thing you can see when treating the neck area or the head area is something called mucositis, which is inflammation of the mucosa or lining of the mouth or the throat. This is very much, similar to what happens on the outside with the skin, the dermatitis. It's inflammation of that epithelial lining of the inside. It's kind of like getting a sunburn on the inside of the mouth, which most people have never had. But just like the skin irritation on the outside, it tends to get better, a few weeks after the radiation's finished. As far as dryness of the mouth, that can happen, certainly as a result of the radiation therapy to that area, as the radiation can affect the salivary glands, on one side of the neck. The good news is that, most of us have functioning salivary glands on both sides. So although in the old days of radiation therapy, when the radiation kind of passed through and through the neck area, these days we have better ways to focus the radiation just to the area where the lymph node metastases are. And we can, prevent some of these long-term dryness type problems that happen after radiation to the neck.
So when patients have mucositis, and they sometimes have trouble eating and swallowing, and what kind of like therapeutic modality do you guys recommend to relieve those kind of side effects, those
Yeah.
symptoms?
So, mucositis in general is an inflammatory condition. And just like inflammation of the skin, we'd use a topical steroid. We often use topical rinses inside the mouth. Those can help alleviate some of the inflammation that's there. If the trouble is with swallowing, sometimes we'll use agents that can kind of coat and protect the surface of the epithelium, in the esophagus. Things like Carafate are very helpful for this. And, I think time is probably the thing that helps the most. Again, on the order of a week or two after the radiation finishes, these types of irritative symptoms begin to get better. So it's a lot of it's just, managing pain and helping folks get through that week or two where the mucositis is proving very symptomatic, and, just helping them get through that period of time.